Hi everyone, this is Mr Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. This is of a patient who attended with some partial occluding earwax in their left ear. In addition, there's a hair strand. You may just see that hair strand. And that hair strand extends right from the entrance towards the eardrum. And if you stay tuned, I do remove that at the end of this video. But the main reason for attending the clinic was their right ear. And as you can see, this right ear is fully occluding with wax. They had been using a cotton bud, also known as I think I said in the past it's called a Q-tip in America, but from what I understand, the generic name is a cotton swab and a Q-tip is a particular brand. I suspect it's like a vacuum cleaner, and it's now called a Hoover, more to do with the manufacturer's name. And they impacted and really compressed this soft earwax right up against the eardrum. What can be quite challenging with this type of wax is that you just don't know how thick the layer is that's coating the canal. So you have to be really, really gentle. If I just poked and prodded that suction probe right over the wax, I might have made contact with the ear canal itself. So we're just gently, again here, because I know I'm near the canal at the top, I'm just hovering over. I just want to reveal the ear canal. And again, we're just at the front here, at the top, and I'm just trying to peel away all the wax around the perimeters, just so I know where I'm working at. I've got an idea of the ear canal volume, the diameter, where the canal wall is, so I'm not going to accidentally bump into it. And you can see in the distance that wax is right up against the eardrum. Now, with this type of wax, it's always best to put some olive oil drops in, as I have now. What the drops does, it's very similar to the procedure yesterday in that respect. The drops binds this wax together. When this wax is so loose and soft and mushy, it comes out in little pieces, and we want to bind this wax together so it comes out in larger chunks. In addition, because it's compressed against the eardrum, I want some lubrication there because we want to take it off the eardrum. Believe it or not, but the eardrum has actually got the outer layer, which is made up of a thin layer of epithelial skin. It's actually quite sticky. So this wax can adhere itself also to the eardrum, and the oil just helps to bind it and lubricate it off the eardrum. So you can see a tinge of blue at the bottom, at the base, at 6 o'clock. That's the patient's eardrum. Even at this stage, they reported to be able to hearing much, much better. But of course, we want to get all this out as much as possible. And to the right, that's the anterior canal wall. We've got to be really gentle. We don't want to make contact with that. You can see it's a very small margin of error there. And this wax is slightly stuck in the anterior recess to the right. There's a little trench or cave, a recess there. And quite often wax can get trapped. So I just put some more oil in here just to really loosen this wax and bind it so it comes out in bigger chunks. And we're just going to the back. So we're right up against the eardrum now, just to give you some perspective in terms of depth. And there we are. So the oil's done its job. So it's going to re-enter the ear. Eardrum is fully visible. There is a bit of a puddle of oil there at the bottom. So I'm just going to go back in a moment with a fine end suction probe just to vacuum some of that. The eardrum is intact. They have got very transparent eardrums. Eardrums typically are more translucent, but with this patient, it's a bit more transparent. You can see through a bit more than the norm. And I can actually see around 10 o'clock, that's their incus bone, almost like the inverted L. And also their chorda tympani, which is the nerve of taste, just above that, in between the inverted L and the hammer bone, which is the bone that extends from 12 o'clock to the middle of the eardrum. So just mopped all this up near the entrance. The patient can hear significantly better. Of course, we advise the patient not to use any cotton swab, or as they're known in the UK, cotton buds. It's just counterintuitive and counterproductive. Your wax is trying to make itself out. In most instances, the skin that lines the ear canal is like a conveyor belt, and as that skin dies and sheds, it comes outwards, and any wax sitting on the surface hopefully would also come out with the skin. So first of all, we're just going to remove this partially occluding wax. Again, you can see the stickiness. It's adhered itself to the base of the ear canal, and you can see all this dead skin has also become detached. There's a bit of skin just at the entrance. We'll remove that. Again, you can see the patient's incus, the middle ear bone. And you can normally see the incus for one of two reasons. If the patient's got a very transparent eardrum, as this patient has, and the younger the patient, the more transparent the eardrum is, and as we age, it becomes a bit more opaque and a bit more difficult to see through. But also, if the eardrum's sucked in, if it's buckled inwards, now there's a slight retraction there at the top. You can see the eardrum, the membrane, it's wrapped around the top part of the hammer bone. That top part of the hammer bone, the rounded bit, we call that the short process, or the lateral process of the hammer bone. And the eardrum, the membrane is just wrapped over at the top. And that's what typically happens when the eardrum gets buckled inwards. It's normally at the top, the attic region, where it creates a little pocket. It's not retracted enough to start collecting dead skin. If that was the case, that dead skin, it can get trapped in the pocket at the top of the eardrum if it's sucked in significantly. And that can potentially lead to a cholesteatoma. So the patient has got a bit of eustachian tube dysfunction. That's the pressure equalizing tube at the back of the eardrum that attaches itself to the back of the nose and nasopharynx, and the function of the eustachian tube is twofold. It's to allow the air to enter or exit the middle ear so it can equalise the air pressure with the atmosphere, and if it's blocked, there's no air pressure behind the eardrum, it's a negative pressure, should I say, and the eardrum gets sucked in. So I've just got some forceps, and it's got, again, just you can see to the left, the top jaw so close to the bony part, we've managed to just to glide it in and pull that strand out. And the eustachian tube is also a drain pipe. So it allows any fluid that collects behind the eardrum in the middle ear cavity to drain away. Well, I hope you enjoyed that video, guys. Take care, keep well, remember, be nice and be kind to each other. Thank you, bye.